I would like to do two things to get us started. First is to begin with Nelson Michael and go around and have each commission member introduce himself or herself.
I'm Nelson Michael. I'm an HIV researcher at the Walter Reed Army Institute of Research.
Good morning. I'm Anita Allen. I'm professor of law and philosophy at the University of Pennsylvania in Philadelphia.
I'm John Aris. I'm a professor of philosophy and public health ethics at the University of Virginia.
I'm Nita Farahani. I'm a professor of law and philosophy and a professor of genome sciences and policy at Duke University.
I'm Stephen Hauser. I'm professor and chairman of the Department of Neurology at the University of California, San Francisco.
Barbara Atkinson, Emeritus Executive Vice Chancellor at University of Kansas Medical Center.
I'm Raju Kushalapati at Department of Genetics and Medicine at Harvard Medical School.
I'm Christine Grady at the Department of Bioethics at the NIH Clinical Center here in Bethesda, Maryland.
And Dan Solmacy, the Department of Medicine and Divinity School at the University of Chicago.
Great. And the second thing I'd like to do is invite our executive director, Lisa Lee, up here to the table to give us a brief overview of the landscape in the ethics of incidental findings. Lisa, so you could kick us off in that way. Welcome.
I'm happy to be here. Good morning, all. As Dr. Gutman mentioned, the Commission started considering this issue of incidental findings over 2 years ago when we first started our work on whole genome sequencing. Do I have a clicker? Oh, thank you. Thank you, Nancy. I'm going to just go over quickly the scope, modalities, and the context of incidental findings. All of this overview will be fleshed out during the meeting today. I'm going to start with scope. And I'm going to talk a little bit, in Privacy in Progress, we defined incidental findings as information gleaned from whole genome sequencing research or clinical practice that was not intended or the expected object. There's debate in the literature about the definition and the importance of clinical significance, reproductive significance, misattributed paternity or parenthood. So we're going to start with this working definition of information gathered in the clinical research or direct-to-consumer setting that was not in the intended aim of the test. And we'll talk about this in the context of potential clinical, reproductive, or health significance. Now, some really dislike this term, incidental findings, and have suggested other terms entirely, like serendipitous or iatrogenic findings, or non-incidental secondary findings, unanticipated findings, a whole bunch of different synonyms, but for now, we'll stick with this. Broadly, there are practical, legal, and ethical considerations here. In terms of returning results, it's unclear whether all persons who have these results have the necessary expertise to understand appropriately and convey the necessary information to people receiving these results, raising concerns around professional ethics and our expectations of persons giving these results. The practical considerations around managing and interpreting and taking into account individual recipient preferences, also an issue, raising issues related to autonomy and beneficence. Legal considerations, any test results that can be returned must be conducted or in a CLIA-certified laboratory, and this might not be the case, particularly for tests conducted in a research setting. In addition, if incidental findings are discovered, there may be issues associated with a healthcare provider choosing not to return them, yet being concerned about legal liability in the case of future potentially preventable damages, then being concerned about avoiding this potential liability, and healthcare providers might conduct then more tests and additional things that would result in potentially more incidental findings. So this idea of defensive medicine. The ethical considerations, this project really presents us with an opportunity for timely deliberation of how ethical principles give rise to particular duties, the duty to look, the duty to warn, the duty to rescue, the scope and stringency of which might vary depending on each of these particular contexts. On this topic, we'll hear this morning from Dr. Ruth Schwartz-Cohen, who will provide us with a broad perspective on things that should be considered in assessing these emerging technologies. Dr. Robert Green has thought a lot about incidental findings in his scholarship and in his leadership of the American College of Medical Genetics and Genomics, and he'll talk with us about recommendations to returning genetic incidental findings in the clinic. And Dr. Mildred Cho, who will provide us with a deeper understanding of current issues associated with incidental findings broadly, and a sense of which issues associated with this are still unsettled. We're going to talk a little bit now about modalities. The three listed here we discussed. With genetics and genomics, obviously we're going to talk here about the whole genome sequencing, whole exome sequencing, other large-scale testing. Not about discrete testing that gives us an answer for a single test without additional information, but these large-scale testing. The types of incidental findings, some are known, like a predisposition to Alzheimer's or BRCA, et cetera, the breast cancer gene. But an individual will have thousands, hundreds of thousands of variants that we don't know what they mean yet. And that's an incidental finding that, as Dr. Wagner suggested, is a whole different set of circumstances. Specifically, in terms of considerations that apply just to genomic incidental findings, there usually aren't additional tests that need to shed more light, that need to be done to shed more light on the findings, but it does lead to potential additional preventive measures, like for the example of BRCA, it might lead to something like a preventive bilateral mastectomy, pretty substantial intervention, or additional screening procedures like routine mammograms. So the implications can be enormous. Most findings are predictive about propensities. They are not, they can't predict with certainty. So there are those issues too specific to genomics. And finally, there might be implications for relatives who might or might not have consented for any of this information. For imaging, so this includes scans, x-rays, ultrasounds, other imaging. Incidental findings of scans of the abdomen and pelvis might include things like liver, kidney, adrenal glands, et cetera, and they're likely to reveal masses that indicate cause for concern. Specifically to imaging incidental findings, some percentage of these masses are benign. Much smaller percentage of these are likely to be something harmful. CT angiography, for example, which is a technique that evaluates the heart using imaging, over 50% have some kind of finding, at least one non-calcified nodule. Less than 1% of these are of concern or malignant. That means 99% of these are benign. But follow-up can produce lots of anxiety, be costly, they have high morbidity risks, and further investigation can generate additional incidental findings. For biological samples, we're talking here about blood, urine, et cetera. This, in terms of types of incidental findings, you do a chemistry screen. It's a panel of 14 tests that is just a broad kind of screening. Includes kidney function, liver function, electrolyte and fluid balance. The test is intended to look for appropriate levels in one area and reveals abnormal levels in another. Healthcare providers are trained generally to only test for what they're looking for and to not do other tests, but only those that will change patient management. Careful consideration, therefore, is given to whether they should order a renal panel, for example, with 7 measurements versus one with 20 measurements. Healthcare providers are well trained in this. But once abnormal findings are found, it's really difficult to ignore them. Specific considerations to biological incidental findings is that a healthcare provider can anticipate a finite set of incidental findings with these kinds of tests. It's not like genomic sequencing where who knows what you're going to find. It's pretty controlled in this setting. All right, let's talk a little bit about contexts. So in the clinical context, incidental findings arise when a healthcare provider conducts a test with the goal of diagnosing one thing and finds something else. The ethical considerations here are that the healthcare provider we all very familiar with this, the fiduciary duties to patients. And I say healthcare providers, I'm not talking specifically physicians. I really mean this in the broadest sense, including physicians, nurses, laboratory technicians, genetic counselors. And it really involves here reconciling beneficence and non-maleficence. It's not always clear that returning incidental findings will provide more benefit than harm, and it's really that we need to think about, how the duties to look, the duty to warn, the duty to rescue actually apply in this setting. There are laws that govern the return of incidental finding, and the healthcare provider's duty, the legal duty to warn or to return incidental findings exists. And again, the concerns about the defensive medicine is a concern. Additionally, reimbursement is a potential practical consideration. It's not clear that insurance will always reimburse for this. And additionally, some insurance claims might lead to incidental findings being treated as pre-existing conditions. So there's that concern. So overall, healthcare providers are generally thought to owe a fiduciary duty. It raises the question of when returning incidental findings is in the best interest of patients. So on this topic today, we'll hear from Dr. Javi Moraim, who's a philosopher and a lawyer, and will speak on fiduciary duties owed to healthcare providers and the way in which obligations that healthcare providers have is distinct from the duties that researchers have to participants. Dr. Danielle Ofri will share her experiences as a healthcare provider and her experiences dealing with incidental findings. And finally, we have Ms. Carol Krukoff, who will share her story as a recipient of incidental findings in a clinical setting. The research context. Here we have a variety of research protocols that give rise to a variety of research participant relationships. These protocols have the potential to give rise to a variety of incidental findings, as you might imagine. So the ethical considerations here are things like the potential incidental findings and the constraints of the researcher's ability to return these findings, both in terms of their expertise and in terms of the obligations they owe their research participants. What do they owe them? Is a partial entrustment model informative? Again, we're considering the duties to look, to warn, and to rescue in this relationship. Again, there are legal considerations. We talked earlier about the implications of CLIA, that laboratory tests and such must be done in a CLIA-certified laboratory in order to be returned. If the data are de-identified, re-identifying them might not be appropriate, possible, or legally permissible. There is a small possibility or concern about legal liability for researchers returning incidental findings, but this is currently unlikely. So there's varying degree of skill and expertise among researchers to both detect, interpret, and communicate findings. Research-grade imaging is often insufficient for clinical interpretation, big practical concern here. Researchers also have limited budgets, and to expend the money on in the pursuit of generalizable knowledge, which is what they're doing, versus whether they should return incidental findings or spend the money in that arena. And then, of course, the question of what is appropriate for an IRB. So there are a number of models and approaches that have been used for returning incidental findings to research participants, and they consider a variety of factors, including how practical it is to return the results, whether the results and the findings are actionable, et cetera. To address this question today, we're going to talk, a couple of folks are going to talk with us. Dr. Alex John London, who is a philosopher, will talk with us about setting forth the obligations that researchers owe to participants and the ways in which the ethical obligations are distinct from healthcare providers. Dr. Peter Bandettini will talk with us about his research and neuroimaging expertise. And Dr. Sarah Hildenberg is a recipient, and she will talk with us about finding an incidental finding and her participation in a neuroimaging study, and she credits this incidental finding with saving her life. Finally, in the direct-to-consumer context, here we have this interesting intersection of medical ethics and business ethics. This is a relatively recent emergence, so we have this ethical terrain that is the least explored. All of the modalities are offered here in the direct-to-consumer context, so we have all of the ethical considerations from the 3 different modalities. Given the scope of what will be returned, given that that's generally set forth in the contract at the outset of the procedure, there are questions about how and when, or even if, direct-to-consumer testing can give rise to incidental findings. So we have the ethical considerations of ethical principles of business ethics, what obligations do direct-to-consumer companies have to consumers to return results if it says something clear in the contract that's different. What models or theories can be useful in this case? Stakeholder theory, integrative social contract theory. And then how do our traditional medical ethical principles apply? Beneficence, respect for persons. Should people who are interested, consumers, be involved in decision-making processes? Should we open up a democratic deliberation for this? There have been ethical problems documented with previous investigations with direct-to-consumer genetic testing, and how do these problems intersect with incidental findings should they be considered? And again, how do the duties to look, warn, and rescue apply here? Legal considerations exist, practical considerations exist, and we'll have 3 speakers today on this topic. Dr. Thomas Donaldson will provide us an overview of social contract theory and an account of when companies owe obligations to individuals beyond that set forth in the contract. Ms. Gail Javits will talk with us about some of the parameters of incidental findings in the direct-to-consumer context, including the contractual relationship between the company and the individual consumer. And Dr. Joanna Martin from 23andMe will provide us with a perspective about how one leading direct-to-consumer genetic testing company thinks about handling incidental findings. So we've covered all 3 of the main areas here, and I really look forward today to today's discussion, both our speakers as well as the panel's deliberation. Thanks.
Thank you very much. That was really an excellent overview of mapping the terrain of incidental findings, and also, not coincidentally, mapping the terrain that we're going to cover today with our wonderful group of speakers. Any questions from commission members to Lisa before we move on? I would just say that where you began, which is with a very a clear definition which doesn't beg the question, is I believe the right place to begin. A lot of people, or some people, want to define it so as to basically bias the conclusion one way or another. In other words, to narrow the notion, the very definition of incidental findings, so it leads you one way or another. Whereas the definition that we used in whole genome sequencing and the one you presented it doesn't beg any question. It's a broad definition which allows you to look at all the different ways in which incidental findings arise, and then we can use empirical and ethical considerations to reach conclusions rather than have the definition itself lead you to a conclusion. It basically says, just to write, an incidental finding is something, in whichever modality you're using, it's not what you're looking for. It's something you find that you weren't looking for. And then it just opens up the question, what should you do with it? Good? We're ready to move on.